Hello, I'm Dr. Namfez, and today we are going to study the cardiovascular pharmacology. In the cardiovascular system, first issue that we need to treat is the hypertension. For the treatment of hypertension, we need to know that what is the cause of hypertension and what are different issues that are associated with the hypertension, or if the patient has comorbidities, or with the hypertension patient has heart failure or diabetes, asthma, patient is pregnant. In all those issues, how do we have to manage the hypertension? For primary hypertension, that is also called essential hypertension, the medications that we use are ACE inhibitors like pramipral, captopril, then angiotensin II receptors blocker like losartan, candesartan. Then comes the thiazide diuretics and loop diuretics. In the loop diuretics, the common injection like Lasix that contains furosemide, and in thiazide diuretics like hydrochlorothiazide. Then we also use the calcium channel blockers. There are two types of calcium channel blockers. And for primary essential hypertension, we use dihydropyridine calcium channel blocker. For example, amlodipine. A patient who has hypertension, that is primary hypertension, we start the treatment of patient with the ACE inhibitors like captopril, pramipral. There are different medications there are different brands that make these medicines, and these medicines comes in the different dosages like 5 mg, 10 mg, and then captopril mostly in the dose of 25 mg. We have amlodipine calcium channel blocker in the dosage of 5 mg and 10 mg. We always start with the ACE inhibitors or angiotensin II receptors blockers unless there is some contraindication associated with that. Then we keep on adding the second medicine if the blood pressure is not controlling. Initially, we increase the dose of first class medicine, and if the patient has a rebound hypertension or the blood pressure is not controlling, we add second class, like we can add loop diuretics or calcium channel blockers, or we can add thiazide diuretics. So this information, I'm sharing the key points for the management of primary hypertension. Next, continue towards the treatment of hypertension with heart failure. For the treatment of hypertension with heart failure, we can give the ACE inhibitors, ARBs definitely, but we can also give diuretics to reduce the preload in the case of heart failure. Diuretics are very effective. Then we can add beta blockers to slow the heart rate in the case of compensated heart failure. There are some medicines called aldosterone antagonist like spironolactone and eplerenone. We also use these medications in the situation when the patient have hypertension with heart failure. One thing that we have to keep it in mind, that be very careful when you are giving beta blockers in a patient with decompensated heart failure, because beta blockers are usually not given in decompensated heart failure, because the beta blocker can worsen the heart condition by further reducing the heart's pumping ability. While usually we give beta blocker for long-term management of heart failure, their negative inotropic effect, that is reducing heart muscle contractility, can be detrimental in the acute setting when the heart is already struggling to pump the blood effectively. So that's why be careful when you are prescribing beta blocker in decompensated heart failure. Beta blockers are also contraindicated in cardiogenic shock for the same reason. In a patient who has heart failure, angiotensin receptor blockers are sometimes combined with the neprilysin inhibitor like sacubitril. So why are we adding neprilysin inhibitor, that is sacubitril, with the angiotensin II receptor blockers? Actually, sacubitril is very beneficial in heart failure patients, because sacubitril, when it inhibits neprilysin, it actually increases the level of natriuretic peptides. These natriuretic peptides are natural substances that help body to get rid of the excess salt and water. It also relaxes blood vessels, and that's why it reduces the workload on the heart. So neprilysin inhibitors, that is sacubitril, it also has an adverse effect that it increases the level of angiotensin 2. That's why we give angiotensin receptor blockers in combination with the neprilysin inhibitors, that is sacubitril, to avoid the effects of increased angiotensin 2. So at the same time, while sacubitril is increasing natriuretic peptides to ease the heart, it is also increases the level of vasoconstrictor, that is angiotensin 2. That's why we give angiotensin receptor blockers, so that we get excess benefit from the combination of these two drugs. So next, let's talk about hypertension with diabetes mellitus. The patients who have hypertension, and with the hypertension they are also have the issue of diabetes mellitus. If we give such patient ACE inhibitors, angiotensin receptor blockers, similarly we can also give beta blockers, calcium channel blocker, thiazide diuretics. Actually, ACE inhibitors and angiotensin receptor blockers, these are protective against diabetic nephropathy. That's why these are preferred. Why these are protective against diabetic nephropathy? Because of the inhibition of the vasoconstriction effect at the efferent tubules of the glomeruli in the kidneys. So why ACE inhibitors are effective in the diabetic nephropathy? Because ACE inhibitors inhibit the vasoconstriction at the efferent arterioles of the glomeruli. In other words, ACE inhibitors and angiotensin 2 receptor blockers helps in vasodilation of the efferent arteriole, and in this way, this dilation reduces glomerular pressure, helping to protect the kidneys, particularly in conditions like hypertension, CKD, and diabetes. So that's why these medications are preferred. One thing with the beta blocker in such patients, that beta blockers can mask the hypoglycemic effects of patients with diabetes mellitus. That's why we are always careful with the beta blockers. What does that mean, that beta blockers can mask hypoglycemia symptoms? It means that actually beta blockers, they interfere with the body's normal response to low blood sugar. We know that when a patient is in hypoglycemia, the patient has low blood sugar, there is tachycardia and tremors, anxiety, patient can have sweating. And these beta blockers, they block the effects of hormones like adrenaline, which normally triggers a rapid heart rate like tachycardia, tremors, anxiety during a hypoglycemic episode. So this can make it harder for people with diabetes to recognize when their blood sugar level is dangerously low. That's why we have to be careful that beta blockers inhibit hypoglycemic symptoms in diabetic patients. Next comes hypertension in pregnancy. A patient who has a female lady who is pregnant, we cannot give other classes of medicines, but we have to be careful. We can give only following medicines. We can give methyldopa, we can give labetalol, then nifedipine and hydralazine. These are the choices. There is a mnemonic for that. He likes my neonate. H for hydralazine, L for labetalol, M for methyldopa, and N for neonate. But I don't advise you to go for the mnemonics. These are very easy medicines that are used normally when you are doing your practice. So you have to be careful that 4 medicines. Simple is if you go for alphabetically: H, L, M, and N. Hydralazine, H for hydralazine, L for labetalol, M methyldopa, and N nifedipine. Nifedipine is calcium channel blocker. Hydralazine acts on the blood vessels. It is an arteriolar dilator. Methyldopa has alpha-2 agonistic action. It decreases the adrenergic outflow by alpha-2 agonistic action from the central nervous system. So alpha-methyldopa is actually converted to methyl-norepinephrine in the central nervous system to decrease the adrenergic outflow, leading to reduced total peripheral resistance and decreased systemic blood flow. Then comes the labetalol. Labetalol, it blocks both alpha-1 and beta adrenergic receptors, so that's why it slows your heart rate by blocking beta-1 receptors and dilate your blood vessels by blocking the alpha 1 receptor. So it's a combined alpha beta blocker drug. It is non-selective for both beta 1 and beta 2 and selective for alpha 1 receptors. So this is important to keep it in mind. Then comes hypertension in asthma. How to treat a patient who has hypertension as well as asthma. There are certain medications that you can't prescribe in an asthmatic patient, like beta blockers are avoided because non-selective beta blockers, they have beta 2 antagonistic effects and they can induce bronchoconstriction. We know that there are beta 2 receptors in the lungs, and beta 2 receptors, when they are stimulated, when some agonistic medication, beta 2 agonists act on those receptors like albuterol, they cause bronchodilation, reduce the asthma situation. But if the patient is taking some beta 2 medicines for hypertension or heart associated condition, then they also have some effects on the beta 2 receptors of the lungs, and those medicines can cause bronchoconstriction. So that's why there are certain medication that we can prescribe patients for the treatment of hypertension and asthma. We also avoid AC inhibitors because they can cause angioedema and can induce cough because of increased bradykinin and all those effects. So the medications that we can use in asthma for treatment of hypertension are angiotensin receptor blockers, then calcium channel blockers, thiazide diuretics, and cardioselective beta blocker. There are certain beta blockers that are only cardioselective, mean they only act on the beta 1 receptors. We can prescribe those as well for the treatment of hypertension in asthma. Alright, let's talk about the calcium channel blocker. As far as AC inhibitors, angiotensin 2 receptor blockers are concerned, you are well familiar with those medicines, that how AC inhibitors and angiotensin 2 receptor blockers help reduce vasoconstriction effect and help in reduction of blood pressure. Specifically here we are going to talk about cardiac associated medications. So let's start with calcium channel blockers. To well familiarize with the cardiovascular pharmacology. Calcium channel blockers, they are divided into two classes: dihydropyridines calcium channel blockers and non-dihydropyridines calcium channel blockers. Dihydropyridine calcium channel blocker, these are amlodipine, clavidipine, nicardipine, nifadipine, nimodipine, and these act on vascular smooth muscle cells to reduce vasoconstriction. Then non-dihydropyridines calcium channel blockers that act on the heart, these are diltiazem and verapamil. They block the voltage dependent L-type calcium channels in the cardiac and smooth muscles accordingly and decrease the smooth muscle contractility. As far as vascular smooth muscles are concerned, the dihydropyridine calcium channel blockers, amlodipine and nifedipine, has equal effect, and they have more effect than diltiazem and verapamil. So the order is that amlodipine and nifedipine have equal effects on the vascular smooth muscles, and after that diltiazem, and in the last verapamil. This is the order of their smooth muscle vasodilation effect. That's why most of the antihypertensive calcium channel blocker that are used commonly in the antihypertensive class are come with the salt name amlodipine. Then on the heart, verapamil has the greatest effect. Then comes diltiazem, and then amlodipine and nifadipine also have some effect on the heart smooth muscles. Dihydropyridine calcium channel blockers, except nimodipine, helps not only in the hypertension but also in angina, including vasospastic type of angina. Then there is a Raynaud phenomena of smooth muscle vasoconstriction. We cannot go into the detail of the Raynaud phenomena, but when someone is exposed to cold, there is vasoconstriction of the vessels, and there is the fingertips start damaging, and there are some other effects that comes in the Raynaud phenomena, and calcium channel blockers help in reducing those effects caused by the vasoconstriction of the vessels in the Raynaud phenomena. Then comes other drugs like nimodipine. Nimodipine is particularly specified for the treatment of subarachnoid hemorrhage because nimodipine prevents cerebral vasospasm. Then nicardipine, clavidipine, these are used in hypertensive urgency or emergency. Then non-dihydropyridines like verapamil and diltiazem, these are also used in hypertension angina, but specifically for atrial fibrillation, atrial flutter, and cardiac associated conditions. There are some adverse effects of calcium channel blocker like gingival hyperplasia. Then dihydropyridines cause peripheral edema, flushing, dizziness. Most of the patient complain of peripheral edema with the use of these calcium channel blockers. Then comes the non-dihydropyridines that cause cardiac depression, AV block, hyperprolactinemia, specifically verapamil, and then constipation. Most of the patient complains of constipation with the use of this verapamil. Also have to be careful that patient should not take excess dose of these non-dihydropyridine calcium channel blockers because they can cause AV block, cardiac depression. Similarly, like beta blockers, they can reduce the heart rate to a very low level, that's called bradycardia, to less than 50. So the physician always adjusts the dose of verapamil according to the patient condition, patient age, patient atrial fibrillation or atrial flutter rate, heart rate, and other conditions that are particularly associated with that specific person or patient. After assessment, a physician describes the dose of these non-dihydropyridines calcium channel blockers, that is diltiazem and verapamil. Next comes hydralazine. As I talked earlier, it is a arteriolar dilator, vasodilator, that is specifically has more effect on the arterioles than the veins. Hydralazine increases the cyclic GMP level. When it increases the cyclic GMP level, it relaxes the smooth muscles. So smooth muscles relaxation happens due to increased cyclic GMP. So arterioles start dilating, and it has more effect on the arterioles than the veins. And when the arterioles start dilating, and veins also have some of the effects, but due to arteriolar dilator, there is a afterload reduction. Preload is the level of blood. I hope you are well familiar with the terms of preload and afterload. Preload actually shows the filling phase, the amount of blood that is coming into the cardiac chambers. It indicates the preload. Preload, in other words, we can say the volume of the blood at the end of diastole. When the ventricles are fully relaxed, the amount of blood that it receives from the periphery through the veins into that chambers is a preload. While afterload is the pressure in the vessels after the heart, that is pressure in the arteries. And the afterload, in other words, is a pressure that the ventricles must have to overcome to eject the blood from the heart, from the cardiac chambers to the aorta. So this medicine, hydralazine, it helps in afterload reduction by dilating the arterioles, by relaxing the smooth muscles of the arteries, by increasing cyclic GMP levels. There are some adverse effects of hydralazine like compensatory tachycardia. That's why it is contraindicated in angina and coronary artery disease. It can also cause fluid retention, and most of the questions in USMLE, MRCP, they ask this side effect of hydralazine, that it causes fluid retention and it causes drug-induced lupus. It can also cause headache and angina-like symptoms, but you must have to keep it in mind. It can cause fluid retention and it can cause drug-induced lupus. It is different from that calcium channel blockers effect that cause peripheral edema. This effect is fluid retention. Most of the students mix these two side effects. Calcium channel blockers, they cause peripheral edema, while hydralazine causes fluid retention. Next comes the drug like labetalol, clavidipine, phenoldiazepam, nicardipine, nitroprusside. You will be amazed to hear that these are some specific drugs that we used in hypertensive emergency. There are two terms, that is hypertensive urgency, when the blood pressure is too high, while hypertensive emergency is that when the patient has some end organ failure with the hypertension. So in those situations, we can give some specific drugs like I mentioned, labetalol, clavitipine, phenoldopam, nicardipine, and nitroprusside. Nitroprusside and phenoldopam. You are familiar with the other drugs like labetalol, clavitipine, and nicardipine. Clavitipine and nicardipine, these are similar calcium channel blockers. Labetalol is alpha 1 and beta blocker. Let's talk about these two different drugs, nitroprusside and phenoldopam. Nitroprusside is a short-acting vasodilator. It has equal effect on the arteries and veins. Very important. Nitroprusside has equal effect on the arteries and veins. It increases cyclic GMP via direct release of nitric oxide, and we know that nitric oxide is a vasodilator. This drug can cause one of the main side effects that is asked almost in most of the exams. It's an important MCQ. It's an favorite MCQ that nitroprusside can cause cyanide toxicity because it releases cyanide. That's why you have to be very careful while prescribing this drug. Sometimes they give a complete scenario where it mimics that patient has cyanide poisoning, but the cause of that is nitroprusside. They ask you that what can be the reason. It is drug associated, is it cyanide poisoning, and you immediately trick that cyanide poisoning. But actually, if the patient has some cardiac issue, patient has hypertensive emergency, then most probably it can be drug induced. They don't mention the drug, that which drug the patient is taking, but you have to use your brain at that time that it can be nitroprusside. Next comes phenoldopam. Phenoldopam is a dopamine 1, that is D1 receptor agonist. It is coronary, peripheral, renal, and symplectic vasodilator. It decreases blood pressure. It increases natriuresis. Also, it is used post-operatively as an antihypertensive. The side effect of phenoldopam is that it can cause hypotension and tachycardia. So I'm repeating again, phenoldopam is a dopamine receptor agonist. It dilates coronary vessels, peripheral vessels, renal vessels, and symplectic vasodilation. Next, we are going to talk about nitrates that are important drugs in the cardiovascular pharmacology. Nitroglycerin, isosorbide dinitrate, isosorbide mononitrate. We are well familiar with these nitrates. These drugs vasodilate by increasing nitric oxide in the vascular smooth muscles, leading to increase in cyclic AMP and smooth muscle relaxation. So, nitrates vasodilate by increasing nitric oxide in vascular smooth muscles. So, this increased nitric oxide, how does it come? There is actually increased cyclic GMP level, and that increases the nitric oxide level, and it causes the smooth muscle relaxation. One particular thing that is very important to note about nitrates, it can lower your BP. You have to be careful. It decreases the preload. It has more effect on the veins. More effect on what? More effect on the veins. It dilates veins more than the arteries. So it's basically a vasodilator. We talked about hydralazine. It is a arteriolodilator. We talked about nitroprusside. It is both arteriolodilator and vasodilator. And now we are talking about nitrates. It's a vasodilator. Nitrates are used in angina, acute coronary syndrome, and pulmonary edema. The patient who have sudden angina-like symptom, we ask them to keep that tablet in your pocket and you can chew. But if your blood pressure is in the range of 100, below 170, then you have to be careful because nitrates also reduce your blood pressure. If you have angina-like symptoms, it's better to take 1 Disprin 300 mg, not 4 Disprin. Some patients think that they have to take 4 Disprin. That these are 4 Loprine 75 mg. But Disprin is already 300 mg, and if the patient has BP on the lower side and has angina-like symptom, in that case, patient can chew a Disprin tablet. But if the patient BP is in the upper range, 120, 130, 120 by 80, then the patient can take half the NGCID or 1 NGCID accordingly, but must monitor the patient blood pressure because excess reduction in the blood pressure, excess hypertension can also cause syncope or patient can faint due to this medication. Then comes adverse effects of nitrates. As I'm talking about the adverse effects already, there are some other adverse effects. These drugs can also cause reflex tachycardia that we treat with beta blockers, because when you are vasodilating veins and reducing the preload, it gives signals to the receptors that patient have blood pressure is loading, so the heart start pumping more. The tachycardia starts. So this tachycardia is called reflex tachycardia due to nitrates intake, and so that's why we give beta blockers to overcome that effect. Hypertension, I've already talked about. Nitrates also cause flushing. Nitrates also cause headache. That's called Monday's disease. In actually, the patients or people who get exposed to nitrates as an industrial workers, that's called industrial exposures, when they come after the work, they have that severe symptoms of headache. Actually, Monday disease is also known as nitrate withdrawal or nitrate-induced headache. Is a phenomenon observed in workers who are exposed to nitrates, particularly in industries like dynamite manufacturing. In this case, when the patient has nitrate exposure, nitrate withdrawal effect, there is not only headache, but patient also feels tachycardia and dizziness. But headache is more pronounced upon re-exposure to nitrates after a period of reduced or no exposure, because on the weekend, Saturday, Sunday, the person is at home, the person is away from the nitrates, there's reduced dose of nitrates. But on the Monday, when the patient goes to the work again, there is re-exposure to the nitrates after a period of reduced or no exposure, and this causes headache, dizziness, tachycardia, and this is due to the development of tolerance to nitrates during the work week, followed by return of sensitivity during the nitrate-free period. That's called Monday disease due to nitrates. Nitrates are also contraindicated in certain conditions. Please keep these conditions in mind. Nitrates are contraindicated in right ventricular infarction. Nitrates are contraindicated in hypertrophic cardiomyopathy. Nitrates are contraindicated with concurrent phosphodiesterase 5 inhibitor use. First, nitrates cannot be given with phosphodiesterase 5 inhibitors because both can cause hypotension, and the dual effect of both medicines can faint the patient. Phosphodiesterase 5 inhibitors like sildenafil used for erectile dysfunction, and if the patient has cardiac issue as well, a patient goes to cardiologist, and cardiologist looking at his or her heart condition prescribes the nitrates, and then patient goes to her general physician, and without letting know the physician, without bringing it in the knowledge of his general physician or practicing physician, medical physician, that he is also on some cardiovascular drugs, he goes for his erectile dysfunction, and that doctor prescribes sildenafil. That is, sildenafil is phosphodiesterase 5 inhibitor, and the patient takes both medicines, and at that night patient faints and fell on the floor. Why? Because BP get very low with that dual effect of both of these medications. So that's why when combined, the effects of both of these drugs amplified, leading to severe drop in blood pressure that can be life-threatening. So these drugs have synergistic effect. So there is risk of hypertension. So sometimes the doctor advises to look for the time consideration. If a patient has taken phosphodiesterase 5 inhibitor, they should wait a certain period varying by drug, but often 24 to 48 hours before taking nitrates. Similarly, if the patient is on nitrate, they should discuss with their doctor before taking a phosphodiesterase 5 inhibitor. Why nitrates are contraindicated in hypertrophic cardiomyopathy? Nitrates are generally contraindicated in hypertrophic cardiomyopathy because they can worsen the outflow tract obstruction, that is the hallmark of this disease. This occurs because nitrates reduce preload, that is the amount of blood returning to the heart, and afterload, that is the resistance against which the heart has to pump. This can lead to decrease in the left ventricular volume by reduction in the preload and reduction in the afterload, and as a result, this decrease in left ventricular volume can have an increase in the obstruction of the blood flow out of the heart. So that's why nitrates are contraindicated in hypertrophic cardiomyopathy, because they can further exacerbate the patient condition, leading to heart failure. Next, why nitrates are contraindicated in right ventricular infarction? So same is the reason as like with hypertrophic cardiomyopathy, nitrates are contraindicated in ventricular infarction because they can significantly lower the blood pressure by reducing preload. And preload is the amount of blood returning to the heart. So right ventricular is already weakened in right ventricular infarction and compromised. That's why reducing the preload can severely even impair its ability to pump the blood effectively, potentially leading to cardiogenic shock. So now I hope you remember these 3 contraindications of nitrates in your mind in a very good way. Next, move on to the anti-anginal therapy. Anti-anginal therapy, the goal is to reduce the myocardial oxygen consumption by decreasing one or more of the determinants of the myocardial oxygen consumption indicators. So myocardial oxygen consumption determinants are end diastolic volume, blood pressure, heart rate and contractility. So in a patient who has angina-like symptoms, we can give nitrates, we can give beta blockers, or we can give the combination of both nitrates and beta blockers. Nitrates actually reduce the end diastolic volume, they decrease blood pressure, nitrates decrease the ejection time, nitrates decrease the myocardial oxygen consumption. But at the same time, nitrates can increase contractility of the heart, nitrates can cause tachycardia. Both of these are reflex responses of the nitrates. Next comes beta blockers. Beta blocker decreases blood pressure, beta blocker decreases contractility, decreases heart rate, decreases myocardial oxygen consumption. But at the same time, beta blockers can increase the ejection time by slowing the heart rate, and on end diastolic volume, beta blockers has no effect or slightly increase the end diastolic volume. Next comes when we are giving patient both nitrates and beta blockers as an anti-anginal therapy. In that case, the combination of both of these drugs have a beautiful effect. That's why we combine both nitrates and beta blockers. On end diastolic volume, nitrates plus beta blockers combination has slight effect, either no effect or they decreases the end diastolic volume to some degree, because nitrates are decreasing end diastolic volume and beta blockers increases somewhat end diastolic volume. So when combined together, either they have no effect or due to increased nitrates effect, they slightly reduces the end diastolic volume. When combined together, they decrease blood pressure. When combined together, they have little or no effect on the contractility, because nitrates are causing reflex tachycardia and reflex chronotropic effect. That is, chronotropic and inotropic effects caused by nitrates are overcome by beta blockers. Beta blockers are against these responses. Beta blocker decreases contractility, beta blocker decreases heart rate. So when combined together, they have little to no effect on contractility and heart rate. Similarly, on ejection time, when combined together, they have little or no effect on ejection time. When combined together, they both decreases the myocardial oxygen consumption. When someone cannot take beta blocker, if the patient has asthma, then we can switch that patient to verapamil, because verapamil doesn't affect the respiratory pathways. So verapamil can be combined with the nitrates. Next comes pindolol and acebutolol. These are partial beta agonists that should be used with caution in patient with angina, because these pindolol and acebutolol, because these are partial beta agonists, so that's why these drugs can cause sympathomimetic activity or sympathomimetic effects, specifically in patients who have angina or had a myocardial infarction. We have to be careful. Just we were talking about the beta blockers in patients who have asthma. We avoid these beta blockers. So which antihypertensive medication can we give in patient with asthma? We can give angiotensin receptor blocker, but we cannot give AC inhibitors, because AC inhibitors can increase the cough in such patient. The AC inhibitors cause angioedema. AC inhibitors causes cough. That's why we prefer angiotensin receptor blockers over AC inhibitors. We can also give calcium channel blockers. We can give thiazide diuretics, and there are some cardioselective beta blockers for the treatment of hypertension in asthma. The non-selective beta blockers are avoided generally Beta 2 receptors, actually, these beta 2 receptors drugs induce bronchoconstriction. That's why we have to be careful. We also avoid AC inhibitors, as I talked about, to prevent confusion between drugs or asthma related cough, because sometimes patients have cough due to asthma, and sometimes the patient does not have cough due to asthma, but the patient is on AC inhibitors, and now the patient present with cough. We can think that the patient has cough due to AC inhibitors, or we can not differentiate. We will become confused whether the patient has cough due to asthma or cough due to AC inhibitors use. So we avoid that these drugs as well. Let's talk about some cardiac specific drugs. First, I was talking about sacubitril. That's a neprilysin inhibitor. It prevents degradation of natriuretic peptides like atrial natriuretic peptide, ANP, and then BNP. Sacubitril, it also has angiotensin 2-like effects. It also increases substance P level, leading to different effects accordingly. But specifically due to degradation of natriuretic peptides, it increases ANP, BNP, and causes vasodilation. It also reduces extracellular fluid volume. It is used in combination with valsartan and ARB to treat heart failure with reduced ejection fraction. Adverse effects of sacubitril are hypertension, hyperkalemia, cough, dizziness, and it is contraindicated with AC inhibitors due to angioedema. So when two drugs are causing the same effects, we avoid those drugs. Just like AC inhibitors, sacubitril also causes increased bradykinin levels. AC inhibitors and sacubitril or neprilysin inhibitor both can cause angioedema. So always avoid the combination of these two drugs. Next comes ranolazine. Ranolazine is given in patients who have angina refractory to other medical therapies. Ranolazine inhibits the late phase of inward sodium current, thereby reducing the diastolic wall tension. Ranolazine reduces the diastolic wall tension by inhibiting the late phase of inward sodium current, and that's why it's not only reduces the diastolic wall tension, it also reduces oxygen consumption. It does not affect heart rate or blood pressure. We are giving this drug in patients who have angina refractory to other medical therapies. The side effects of ranolazine are constipation, dizziness, headache, and nausea. So patient can not only complain of constipation with the use of verapamil, the non-dihydropyridine calcium channel blockers, but ranolazine can also cause constipation. So most of the patients who are on cardiac medication, sometimes they complain of increased constipation. So there are some lifestyle factors as well as there are some drug associated factors. Now let's talk about cardiac glycosides, digoxin. Digoxin, it's a very dangerous drug in a way that we have to be very careful while prescribing this drug. It decreases the efflux of sodium. It decreases influx of potassium. So listen to me, actually digoxin is a direct inhibitor of sodium potassium ATPase. When digoxin inhibits sodium potassium ATPase, it inhibits the influx of potassium and it inhibits the efflux of sodium. Actually, sodium potassium is a counteracting channel. But usually in a sodium potassium ATPase associated channel, potassium is going inside, sodium is going outside, and digoxin is blocking this effect. When digoxin blocks this effect, then more and more sodium keep on gathering inside the cell. As a result, there is another channel called sodium calcium channel that gets inhibited because there is so much sodium inside the cell as a result of the blockage of sodium potassium ATPase. That sodium calcium exchanger, that is also a counter exchanger, stops working because it's not able to send more sodium inside the cell because of increased sodium already inside. So the digoxin indirectly inhibits sodium potassium exchanger. As a result, there is increased calcium because this increased calcium is gathering inside the cell because sodium is not going inside. Sodium calcium exchanger is sending sodium inside and calcium outside, and when it gets blocked, then calcium is not able to come out. It starts gathering inside the cell. This increased calcium has positive inotropic effect. It stimulates vagus nerve and decreases heart rate. The clinical use of digoxin, that's a cardiac glycosides, it reduces contractility. So in a patient who has heart failure, increased contractility, it is helpful. In a patient who has atrial fibrillation, it decreases conduction at the AV node and depression of the SA node. But we have to be very careful. We cannot give digoxin too much because it can depress the AV node and SA node. It can affect the cardiac contractility and heart rate. So adverse effect of digoxin, it has cholinergic effects. It can cause nausea, vomiting, diarrhea. This is sometimes asked in questions. The side effects of digoxins are very important. It causes blurry vision. It causes arrhythmias and AV block. It can lead to hyperkalemia, which indicates poor prognosis. That's why whenever our physician is advising some cardiac medicines, they always go for the serum potassium level. There are certain factors that predispose to digoxin toxicity. Number one is renal failure because there is decreased excretion in that. Number two, the hypokalemia, because hypokalemia is a condition that is permissive for digoxin binding and potassium binding site on the sodium potassium ATP. Then there are certain drugs that displace digoxin from tissue binding sites. And then there are certain drugs that decrease clearance of digoxin like verapamil, amiodarone, and quinidine. If the patient is on verapamil, amiodarone, or quinidine, then digoxin toxicity increases. These all suggestions they can ask in different scenarios. The antidote for digoxin, that first we have to slowly normalize the potassium level. We can use cardiac pacer. There are some anti-digoxin fab fragments. And then magnesium also helps. So slowly normalize potassium. You can use cardiac pacer, then anti-digoxin fab fragments and magnesium. Let's talk about lipid lowering agents. The lipid lowering agents, there are certain classes of drugs we use as anti-hyperlipidemic medicines. The first is HMG coenzyme A reductase inhibitors, for example, atorvastatin, simvastatin. Then bile acid resins like cholestyramine, cholestyramine, colesevelam, and then ezetimibe, then fibrates like gemfibrozil, bezafibrate, fenofibrate. Niacin is vitamin B3 that also helps in act as lipid loading agent. Then PCSK9 inhibitors like lilokumab, evolocumab, then fish oil and marine like medication, marine diet like omega-3 fatty acids. Let's talk about each of these classes for lowering the lipid levels for treating hyperlipidemia. First class is HMG coenzyme A reductase. HMG coenzyme A reductase, for the atorvastatin, simvastatin, rovastatin, these are helpful in decreasing the LDL level more than other. So if you want to decrease the LDL level, LDL cholesterol level, these drugs are preferred. These drugs inhibit conversion of HMG coenzyme A to mevalonate, a cholesterol precursor. It also increases LDL recycling. It decreases mortality in coronary artery disease patients. The adverse effects of statins are hepatotoxicity. That's why cardiologists are very careful. They check the LFTs level. If their LFTs levels are increased, then cardiologists are careful while prescribing these lipid-lowering agents. These statins can also cause myopathy, especially when used with fibrates or niacin. So sometimes patient complains that we were taking these anti-hyperlipidemic drugs from the statin class and they have developed myopathy. There are certain brands that patients become careful that comes with the these statin drugs. Sometimes physicians they reduce the statin dose to help with the myopathy. The fibrates also cause some degree of myopathy when combined with these statins. as well as niacin. Then come bile acid resins like cholestyramine, cholesterol, cholecylamine. These are also helpful in decreasing LDL level, but these are less effective than statins. They prevent intestinal reabsorption of bile acids. Liver make more cholesterol to make these bile acids again. So liver must use cholesterol to make more of these bile acids when these bile acids are not being reabsorbed at the intestinal ileum level. There are some side effects of bile acid resins. These resins can upset GI tree. So GI upset, there is decreased absorption of other drugs, for example warfarin. This question is asked. Then there is decreased absorption of fat soluble vitamins like vitamin A, D, E and K. Next there is ezetimibe. Ezetimibe is a cholesterol lowering, lipid lowering drug that prevents cholesterol absorption at small intestinal brush borders. It also has some effect on decreasing LDL levels. It has less side effects. Rarely it increases LFTs or cause diarrhea, but it is very rare. Then comes fibrates like gemfibrozil, bezafibrate, fenofibrate. These fibrates are specifically designed to decrease the triglycerides levels. These have more effect on the TGs, triglycerides, than other cholesterol levels. Fibrates upregulate lipoprotein lipase that increases triglyceride clearance. Fibrates also activates PPAR alpha to induce HDL synthesis. Fibrates have side effects of myopathy that increases with statins. These fibrates can cause cholesterol gallstone. So if the patient has cholelithiasis, you have to be careful because via inhibition of cholesterol 7-alpha hydroxylase, this question has been asked in the exams many times, that by inhibition of 7-alpha hydroxylase, cholesterol 7-alpha hydroxylase, when it is inhibited by fibrates, it increases the risk of cholelithiasis, that is cholesterol gallstones. Then niacin. Niacin decreases the LDL level more than other cholesterol levels. Niacin inhibits lipolysis that by affecting hormone sensitive lipase in adipose tissue. It reduces hepatic VLDL synthesis. Side effect of niacin, it can cause flushed face. Always remember this flushed face caused by niacin. It can be reduced by the use of NSAIDs or by the long-term use. Niacin can also cause hyperglycemia and hyperuricemia. So be careful if you're prescribing niacin in a patient who has hyperuricemia, has gout. So always be careful. Then PCSK9 inhibitors, elurucumab and evolocumab. These decreases LDL level more than other antihyperlipidemic drugs. PCSK9 inhibitors, inactivation of LDL receptor degradation is the basic mechanism of PCSK9 inhibitors. When there is inactivation of LDL receptor degradation, it causes increased removal of LDL from bloodstream through these upregulated LDL receptors. PCSK9 inhibitors can cause myalgia, delirium, dementia, other neurocognitive effect. Then comes fish oil and marine omega-3 fatty acids. These have slight effects on increasing the HDL level, but they also, when given at high doses, can decrease the triglyceride levels. These fish oil and marine omega-3 fatty acids are believed to decrease the free fatty acid delivery to liver and decreases activity of triglyceride synthesis by decreasing the triglyceride synthesizing enzymes. Fish and marine omega-3 fatty acids can sometimes cause nausea and fish-like taste. So these were main cardiovascular drugs. Now there is a last category that is left, that are antiarrhythmic drugs. Let's talk those antiarrhythmic drugs in the next podcast. There are different classes of those antiarrhythmic. We will discuss in that. Thank you so much for hearing me today. Please like, share and subscribe my channel. There is more to come. Thank you for listening. Take care.